Okay, this is called
got
Editor's
it?
Choice. This
Can you
is
hear
some papers that are not included elsewhere that we thought were fun from this past year. We'll go through them. Your participation is sought out. The first one actually is the paper I prematurely made reference to regarding the, I guess this is the people at Brigham and Women's. Variation in use of head CT by emergency physicians. Let's see here, 38 emergency physicians, 0 to 30 years experience, looking at the rates of head CTs in 2009. They looked at 55,000 visits. Head CTs were performed in 9% overall. Be interesting to know where your ER is compared to theirs. You can jot down, do we do 9%? That's 1 out of 11 people walking in the room get a head CT. Unadjusted rates for scanning varied by physician from 4% to 17%. After adjustment for confounders, requests for head CT scanning varied between physicians by at least twofold. Similar patterns are observed in the subgroup of patients with atraumatic headache, in which the rate, here you go, this is the headache now, patients, in which the rate of headache CTs were 15% for one doctor, 62% for another doctor. And there was some adjustment for confounders, but it still came out to be 20% for one doctor, 60% for another doctor. They were not, the use of head CTs was not influenced by physician gender, good to know, or level of experience. So some doctor have been there 30 years. I have no idea which one of these doctors is the 60% head CTer, but you would hope that over time, the light bulb would go on, but I'm not so sure that that necessarily is true. I think this is a really brave thing for these guys to do. This is their dirty laundry that their faculty said, here's our variation. Can you imagine what the variation is in community emergency departments and other places? I'm sure we could go get 90% to 10% if we worked on it. So it just goes to show you about the variability. It doesn't say who's right, who's wrong, but we got to think that variability like this is a problem.
Well, it's going to be even a bigger problem when ACOs hit. You're going to get a pot of money and that's it. And how it gets spent, it gets spent. And if you have somebody who's ordering 60% scans and somebody else is ordering 10% scans, something's wrong. Something's in the range of practice. And there are behaviors we know. There's the risk-averse people and the risk-taker people, or there's the test orderers and the ones that don't order as many tests. But somewhere along the way, we're going to have to get into a little bit more standard of a practice. And it's not going to be as easy as saying, I like to do it this way. It's going to have to be based on something a little more firm.
Any of your thoughts?
Our nurses don't order that stuff at triage without letting us know.
Ours do.
Yeah.
Well, they do in sort of conjunction with usually a mid-level provider, right? So they don't do it totally independently, but also not without.
Do you have
physician.
guidelines on when they order?
Yeah, but I think they're like stuck to the bottom of somebody's shoe somewhere. I don't believe they're actually followed. Guidelines seem to be just sort of mid-level, discretion, and they're pretty junior mid-levels at our place. So I think we see a lot of unnecessary CT scanning, in my opinion.
If you didn't have the medical legal aspect, how much do you think these numbers would change?
Well, I think that's a really interesting question. I think us over-testing as a community is just, we have to admit that we do it, right? That's a problem. Like the first stage is admitting you have a problem. We do it. But I think that we do it for multiple reasons, and I'm not sure how much of it. Part of it definitely is the medical legal, but I personally believe that it's much more, you don't want to be looked at poorly in the eyes of your colleagues and your peers, right? Because I can only think of those examples where 2 days, you walk into a shift, you were there 2 days ago, and you come in for a shift, and somebody says, hey, remember that guy you saw with a headache a couple of days ago?
Right.
The first thing that pops in my head is never, I'm going to get sued now. That's never what I think. What I think is, damn it, somebody caught something that I missed. Like some peer caught it, and they're about to make fun of me, and I'm going to have to listen to them talk about this for the next 10 years. So I missed the X in this patient. So I don't know how much just a pure medical legal abandonment would diminish these numbers. I mean, there are places where medical legal is a lot less, and you can speak to that probably, Rick. And are the numbers any different there?
Well, you know, I have mentioned this massive malpractice reform that occurred in the state of Texas. Anybody from Texas here? Where, in fact, they changed the rules of evidence. They they put a cap on pain and suffering. They changed this constitution of the state of Texas to accommodate these rules and regulations. They allowed for periodic payments, so there was no lump sum payment. They did about 5 or 6 or 7 different things, and they dropped the insurance rates in the state of Texas by at least 50%. A whole bunch more insurance companies came in. A lot of new doctors came into Texas for sure. And 7 years after this initiative took place, they looked at the utilization, the expenses for Medicare patients. And Texas outspends the national average in terms of the utilization of tests and admissions and those kinds of things. So you could not find any difference in the state of Texas based on just what Medicare spends. But you would think that if it was going to affect testing and CTs and that kind of stuff, that there would be some change in what Medicare spends. In Texas, Medicare spends more in Texas than the national average. Now, doctor, do you have any thought about that in your state?
I think it's the same. I work all over the country, and it's the same wherever I go. We're worried about the lawyers.
Well, in Texas, you shouldn't be worried anymore about the lawyers, and they still are. And my point of view, personally, is if I think medical malpractice went away tomorrow, that it would not substantially affect physician behavior. I really don't. I know that everybody would say that no, but there was a great article in the Wall Street Journal. This is just the way we have learned to do it. Right. And we've learned to do it this way over decades. And so to flip the switch tomorrow and say we don't have to do it because of malpractice, I just don't think it. I think a lot of physicians believe this is the proper way to practice.
Yeah, here, you have a hand? I'm not sure is this mic working, you guys? Okay.
I agree with you. I was in the Army for a while, and that's like I think it's beyond just.
Well, you know, many of the new hires were taught at those places where and so it was monkey see, monkey do.
So it still has to do with their training rather than just.
Oh, I believe so, absolutely.
But the second thing, the piece that I think is an elephant that people are starting to ignore is the patient satisfaction.
Yeah, I was just going to mention, that's actually something I think that drives this.
I think it's large, if not larger than.
So patient satisfaction is the driver of the utilization of these ionizing radiation that's going to make your kid dumber and give you cancer, but it'll make you happy in the meantime.
It's the whole patient expectation thing. And, we don't have relationships and just patient expectation. That's growing as an issue.
Yeah,
So
it's also going to
satisfaction
go,
as
that'll
the
be
driver.
less too. So we're so stuck between a rock and a hard place as far as reimbursement's concerned. I think that has to just get factored out at this point, and good medicine needs to get factored in. But the patient satisfaction thing is real. One of the LLSA articles for 2014 is a study that is incredibly discouraging if you really are an H&P person. I really believe in the bedside evaluation of people, because you just get a lot, you know a lot when you walk away, and tests only add a little bit. And this study looked at patients' satisfaction with what you do based on H&P alone. They're on a scale of 0 to 100. The score was, they're trusting your diagnosis was 20. All you had to do was draw blood, and it went up to 80. The most important thing you could do to get bang for your buck was order a CT scan, and then you got up to almost 90, that they trusted you. They didn't trust you from your H&P. They wanted something else done as an objective something or other. And so the patient satisfaction is an absolutely real deal. And I don't know how to work around this except to try to explain to people that everything has a risk. And even doing testing doesn't mean that it isn't without risk, not just cancer and not going to Harvard, but things like we may find something that's not important in there that's going to lead to more tests. And blood tests, by definition, 5% are going to be abnormal by how they even define what's the normal range. And then you go charging ahead, try to working up an AST that's 5 above normal, or a lipase that's twice normal that may be not significant at all. It just goes crazy, crazy, crazy.
I think also we have to consider how therapeutic those X-rays of the lumbosacral spine are in someone who comes off an industrial injury. When you tell him your X-ray looks all right, oh good, I'm glad I had that. Or how therapeutic a chest X-ray looks, even though you know that it's a simple viral bronchitis, and the patient feels so much.
Yeah, I think that goes right back up to here to this doctor's point about, the patient satisfaction and their set of expectations. The problem is, okay, maybe a chest X-ray every once in a while for patient satisfaction, I could not lose any sleep over. But when we're talking about head CTs, things I know carry significant harm, it's much more difficult for me to sort of, get those two straight in my head. So one more comment or question before we move past abstract number one.
Oh, we always get there.
Well, I think it's very difficult, and Diane and I both work with this kind of thing with residents all the time, and I think you're in a very dangerous place right now, right? And that dangerous place is altering your practice on
Based
the
on a
basis
single
of a
case.
single case that you'll probably never see again in your lifetime. And this is a trap that we are all very easily a victim to fall into, but you have to go in the greater experience of medicine. You have to know that sometimes even the best guideline, like if you follow it, is going to miss something every once in a while. Nothing is perfect. No computer is perfect. No human being is perfect. There's always going to be that weird outlier case that nobody on earth could have predicted would have been positive, and you found it. Like, what you really need to do is try to remember that that is an outlier. That's not the norm, and not everybody with trigeminal neuralgia is going to have some weird freaky. I know, and I know you won't. I'm just saying, sort of for the benefit of everybody in the room, that it's hard.
Right.
It's hard when you get that one case. It'll probably change your practice for a little while, whether you know it or not. But then eventually you got to come back to the norm and come back.
Although
to what
you've
makes
had your
sense.
case, so you're not going to get another.
No, you're done.
Don't worry.
You're done.
But now the person next to her might. Because that's,
Actually,
that's
is
contagious.
And when things go wrong as well, it's worth. We do in training programs. We do M&Ms all the time, and we on purpose every year at our department do 2 or 3 where something bad happened to the patient, but on review of everything, even knowing what happened to the patient, you wouldn't change what you did the first time around anyway. And that's part of this whole reassessment as well, is not beat yourself up because we're being recorded, but shit happens, and it just does. And so you can't beat yourself up for things that no one would have picked up, no one would have known. You have to give yourself a little bit of slack in the fact that we just are in a crazy field, and the human body's a crazy thing sometimes. Aspect number 2 is another radiation exposure thing, and for those of us who work in trauma centers, how many of you work in trauma centers? How many of you are stuck with the pan scan? Oh, for heaven's sakes, this is the craziest thing ever. So we've gone in ATLS from a finger or a tube in every orifice to, we don't need to do that anymore. We just scan everybody from head to toe. That's what we do, which is nuts. This looks at and God bless them for publishing this, but this is a pre and post study that looks at what happened when they instituted a pan scan protocol. And we tend to think of this as, those silly Americans, they do these terrible pan scan things. Well, this is actually from Australia. God bless them, they published this as well. And they looked at how many people got diagnoses made by getting this whole pan scan. Was it better? Did they get better things? Did they find more terrible things that were wrong with people? And then they looked at what was the radiation cost, with the idea that over 20 millisieverts is where your cancer risks goes up. Is once you get exposed to 20 millisieverts, anything from there on out, your cancer risk goes up. They basically found that the people who got a potential cancer ionizing radiation dose went from 12% to 20%, and the missed injuries were no different. Basically, it was just the same. And if you think about the patient population that's getting scanned in trauma patients, it's pretty much young, healthy people for the most part. It's people in car crashes, people fall down, people get in fights, people get shot, whatever. We saw 12 trauma patients in my 8-hour shift last night. So they get scanned like crazy, and they often get rescanned. There's a little tiny subcapsular splenic something or other. Let's go rescan it in a few hours. So now they're getting double the dose. It's a nuts protocol. But I'll tell you, we have tried to fight this battle at our institution 3 separate times where we sat down, we had big meetings, we pulled the literature, blah, 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 blah. And the surgeons have the trump card, which is, it's on my butt. You know, I'm the one that's, you know, out there sticking it out there as far as deciding whether they need OR or not. I need the study. So it's really a difficult problem, but I don't know of any data except one paper out of your joint that shows that pan scanning offers you anything. And the one out of your joint, they didn't examine everybody.
Right.
Examining would be a nice thing first.
Well, I mean, the paper she's referring to, you guys have probably heard him lecture all the time, is Kenji Inaba's paper, you know, from USC, where they found, like, you know, they said they examined everybody before the scan, and they found that, you know, in like 85% of patients or something, we missed something horrible on our physical exam.
Right.
I mean, it was, you know, but it's funny because it's published and everybody's making a big deal about it, but I mean, I have many conversations with Kenji about this afterward, and he's often said, like, my bad, sorry about that. You know, that was obviously a paper that had a lot of methodological flaws. Like, there were patients with, you know, flail chest that apparently were missed on physical exam. You know, I mean, that's what the results said, and it's just impossible that could be
Right,
true.
it is the kind of paper when you read it and you see what injuries were missed,
Yeah.
it's like, on what planet did you not look at this person at all? You know, their decapitation. You know,
You know,
it's like
and
you'd think you'd notice.
But
that their head wasn't on.
But what's funny is, you know, Kenji does a lot of lecturing on pan scanning now, and he does sort of mea culpa this paper quite a bit. And his first slide is always the same slide. I don't know if you guys have seen it. And it's a really great, it's a patient chart, you know, with identifiers removed, and it sort of has like a little brief history, patient, motor vehicle accident, whatever, and it doesn't have a physical exam. It's completely blank. And then there's a thing at the bottom that says assessment and plan, and it says plan, pan scan patient, number 2, physical exam. Like, that's exactly what it says on the chart. So,
How many millions sieverts are in a head in totality in a head, neck, chest, and abdomen?
Oh, that ranges, but the lowest I've seen is 12 and the highest I've seen is 75.
yeah.
So in a single pan scan, you're going to get most people over the cancer risk range in a single pan scan.
I mean, abstract number 3 is very similar, so we may as well just jump right into it. This was actually done just up the road at UCLA, and Jerry is an author on this paper. And basically, they're asking the same question. We're pan scanning a lot of trauma patients, but are we actually finding anything? Here we're looking at 700 patients-ish who got a total of almost 3,000 scans, if you sort of count everything, you know, individually as its own scan. They're all blunt trauma, but they asked both the attendings. They asked the ED attending and they asked the surgery attending before the scan is done, hey, you really think we're going to find anything here unexpected? Do you think this is really a necessary scan? And then they present the results. And essentially what the results were is that 10% of the scans had a finding that was sort of unexpected, like, oh, well, positive, surprised me a little bit. I didn't really know that. But in total, only 0.3% had a finding that there was actually something worth doing about. And they, again, I mean, it's such a small number. There's only 3 or 4 patients, and they list out what the findings were that had a critical action. And I just can't believe that these were surprises either. There was like a multiple rib fracture flail chest patient. There was a subarachnoid hemorrhage patient that didn't do anything with, and there was a T-spine fracture. But then the important thing here is they asked the ED docs, and this I think goes with all of our clinical experience. You know, so retrospectively, would you have gotten all these scans? And they said, yeah, 70% of the time we probably would have pan scanned this patient. That seems about right. And then when they asked the surgery attendings, like we said before, what do you think they said? 99.7% of the time they said a pan scan was totally appropriate, because we found 10% of patients had something that we have nothing to do for. So the answer of are we over scanning? The answer is yes. The question of how much are we over scanning, I think it depends on who you ask. The surgeons generally like the full body pan scan because it's sort of CYA and they can't miss anything, whereas we like to use a little more clinical judgment.
And
That's
last
how I see
night,
it.
one of the patients we had was a woman who's 7 months pregnant who had a very minor mechanism, but was a little tender on her sort of suprapubic area and a little tender where her seatbelt had, no marks, but a little tender where her seatbelt had been. And they wanted to pan scan. I went ballistic. It's like, okay, hang on a second. You know, most of the time, if there's any questions, fine, they get to trump. But this one was just not worth it. And this study basically shows the problem we have, where basically pan scanning, we would have, if we had made the decision, almost half of the pan scans would never have happened. And if the surgeons made the decision, basically 97% of the pan scans would have still been done. So it's just a different point of view. And
I think that paper that had the difference of opinion between the surgeons and the e-docs, had 2 separate conclusions written.
Yeah, that's right.
Each group wrote their version of what we think this
Right.
data means.
I think they actually published 2 different papers. Like the surgeons published their paper in their journal, and we published ours in our journal. That really is true. And we said
all in the spin.
they definitely it's like I said, depends who you ask, gave a totally different conclusion of the same data set. So
We'll cover number 4 on the concussion paper, so we can skip that one.
okay,
Number
number 5. Then.
All right. I just had one thing to say about 4. This is a paper that says it's reasonable to watch kids a while before you scan their heads, which is like makes perfect sense rather than rushing them into the machine, because you may find that, you know, maybe in 45 minutes they haven't vomited, they're looking good kind of thing. I think I changed my mind, when you may have not made that decision when they walked in the door. But the problem with this paper is that the differences between the observed group and the group that had an immediate CAT scan in terms of the total scans they did was so minimal that I like the answer, observe kids before you scan them, but the numbers really don't support it particularly. Number 5 is looking at docs ordering people to be admitted for pneumonia. Hospital costs for community-acquired pneumonia are about 25 times higher than outpatient treatment, they say. This is a look at 2,000 patients with a community-acquired pneumonia, looking at these differences by emergency physicians. The admission rate was 58% overall, but varied almost twofold. From one doctor only admitted 38% of their pneumonia patients. Another doctor admitted 79% of their pneumonia patients. Higher rates of hospital admission, however, were not associated with a decrease in mortality or secondary hospital admission. So this paper, again, just kind of shows variability in physicians without variability in outcomes that are magnitudely substantial. And this is looking at community-acquired pneumonia, but what if you were to take a look at something like maybe even congestive heart failure, which is Medicare's most expensive single diagnosis, and the readmission rates on these patients in terms of, well, can we spiff them up in the observation unit a little bit, or are we going to put them into the hospital directly kind of thing? Because the readmissions in 30 days now, that's going to be one of the things that are looked at under the ACA and all of this other kinds of things. So this says people's wiring are a major determinant of whether the same people get admitted to the hospital or not. I don't know what to do about it, but it's very consistent with the one that says I CAT scan everybody's head and you don't. And you know doctors who order every test in the book, and everybody knows who they are. And then you also know the ones that are kind of the lean and mean and shoot from the hip docs. And you can't really go on how many lawsuits they've had, how many unscheduled return visits they've had, because those are such crude markers and such rare markers that you can't basically differentiate. Well, he's had more unscheduled returns. I mean, the lawsuits are 1 in 20,000 visits, or 1 in 30,000 visits. So it's hard to show that the more conservative doctors are really that much better than the ones who are less conservative.
This decision on when to admit, and the guidelines that were out from the ATS talk about when we should and shouldn't be admitting, or the patients that have pneumonia. For those of us that work in at least USC at Harbor, and some of you may be in this room as well, one of the things that's out there to try to standardize practice is what's called InterQual. You guys familiar? Anybody familiar with InterQual? It's a McKesson product. It's actually a proprietary product that was developed basically to decide by diagnosis at admission where those people go. OBS, ward, monitor, or ICU, or home, which is what you'd like to do with some. And there's literally checkboxes. You know, if you're admitting for congestive heart failure, these are the 4 criteria. They all have to be met, including things like 2 doses of a diuretic before they're admitted. So we take our 40 milligrams and split it into 2 20 milligram doses, and now we meet InterQual. What that's trying to do, though, is and it's evidence-based, and it has some bumps along the way, but it's at least a nice effort to try to standardize what we do so that we don't have this huge variability in practice. And it's based on literature, at least the literature we have so far. For us in the ER, it's a little bit of a pain, because if you don't qualify for InterQual, at least for those of us that work in the county, we don't get paid, or we get paid significantly less if we still decide to admit them. Separate from that, though, and what's kind of nice is it takes this variability in-house, because these InterQual criteria are also applied to in-hospital patients. So someone can't sit on the pneumonia patient for 5 days in the hospital. Someone can't sit on the CHFer who's totally stable and doesn't need to be in a monitored setting anymore. They have to downgrade them. So these kinds of things are getting a little bit, it's kind of sad actually, but they're getting a little taken out of our hands, but at least in a way that's evidence-based pretty much, and trying to standardize our practice. Number 6, oh yeah, please.
Curious about this article on that. I don't know if any emergency physician has admitting privileges. So I don't know anybody who admits patients as an emergency physician. Usually as a hospitalist and private attending. Most places now have case managers as well as screen cases for outsource
Yeah.
admission or go home. But this says that these are emergency physicians who are admitting patients. I don't know anyone who does.
Well, how many people in this room have admitting privileges at their hospital?
Well, to be, I mean, you make the call to get them admitted,
Well,
right?
that's not what this says. This says
Rick, I don't know the details of this paper.
11% readmission, return admission rate on those that went home. That's pretty high.
That's really
10%
high.
or 11% of the patients who they decided to send home came back and needed admission.
But we don't know from that data whether it was from the guy who admitted sent everybody home or the one who sent very few home. You know, the implication is, well, they're coming back from the guy who sent everybody home. And we don't really know that. And technically, you're right. You know, in the community setting, we don't have admitting privileges, but we get patients admitted. You know, we sell them. We make that decision happen.
Not in my hospital anymore. Maybe that used to happen, but now with all the reviews, the CMS reviews, and the audits that are done, it's much more difficult.
Well, you know, it's interesting because if there were criteria being applied to these patients, you would not see this huge variability. I mean, you would think that it would be much narrower range by physician because they're following admission criteria or something like that, but it doesn't appear to be.
The next 4 abstracts, I think it's 4, deal with PE. And the sort of this abstract number 6 is a blend of use of CT or overuse of CT. And well, I'm sure we'll end up spending some time on this topic, but this particular paper, it comes from the National Quality Forum. And what they did is they wanted to look at the use of CTPA and particularly the over or inappropriate use of CTPA in working at PE. And what this sort of launches into is the concept of risk stratification of patients, that we have pretty decent tools out there right now that look at if you're no risk, if you are low risk and what you should be doing at that point, and if you're not low risk, so intermediate or high risk, in particular high risk, and what you should be doing at those points. And there's different sort of protocols that are recommended. And the goal of this now has been switched a little bit. We were talking about this out, Sanjay and I, with one of you out there in the hallway. It's no longer a focus on do you or do you not have a PE. It's more of a focus on what's going to happen to you in the next 30 days, 60 days, whatever's being measured. Because honestly, the reality is we are probably all making and breaking down little PEs all the time that don't hurt us. It's just the big ones that are the problem. So this one looks at the use of CT, and we'll get into some more details on the other ones and the other issues in a second. But this one basically says that if you are low risk clinical suspicion, and however you get there is up to you. You can do that gestalt. I walk away from the bedside and I don't think this is low risk for this person. Or you actually measure. You do Wells criteria. You do whatever of the difference. There's a bazillion scales out there now. You walk away saying the patient is low risk. We're not talking about no risk, just low risk. Their leg's a little sore. They have a little bit of pleuritic pain, but they're not tachycardic. They're not tachypnic. Their SATs are good. They don't really have a risk factor. So I really don't think it's there. If it's just on your radar screen enough to really be concerned, you can get a D-dimer. If that D-dimer is negative, you're done. You don't need to go on any further. You don't need to get a CTPA. And then the no risk is, I don't know, your asthma. Your chest is tight. It hurts when you breathe. You're having your asthma exacerbation. It is your classic asthma exacerbation. There's nothing else going on. You are no risk. No risk gets nothing except whatever there's appropriate care for their other complaint. Low risk gets a D-dimer, and if it's negative, you really are finished. What they did in this paper is they looked at the use of CTPA. And they found that basically a third of the CTs that are ordered are unnecessary. That we're just getting the test because whatever reason we're getting the test. So people are ordering this, what they're calling inappropriately. And to be perfectly honest, I think it is inappropriate. These are patients who really, based on a lot of pretty good data out there, are at very low risk of anything bad happening to them. And the drugs we put them on, if we do catch a PE in somebody where it's inconsequential, the drugs are much more problematic. The break point is now the drug is going to cause them harm. The PE would never have caused them harm, and clinically it's an insignificant PE. So this is what we're launching to a couple of other papers because it's a big discussion point. But this one basically says a third of the CTs that were ordered that they looked at in this huge database were unnecessary.
Yeah, but I mean, this is consistent across multiple papers that look at big national databases and that look at sort of single institutions that all say the same thing, that we have this algorithm which we propose to believe, which is low-risk patients with a negative D-dimer don't need a CT scan, and we follow that algorithm maybe half the time. I mean, that just what all the literature says the same thing, is that we're not, I don't know if we don't believe it, I don't know what the problem is, but that there is a big problem there. Abstract number 7 is not looking at PE specifically, it's kind of more looking at the use of CT scan. This is a NAMC study where they essentially looked at 2 different periods in time, 2 fixed periods of time. They looked at a period between 1997 and 1999, and then a period that's close to a decade later, so between 2005 and 2007. And in total, they looked at about 17,000 visits of patients who came in for chest pain, some kind of sort of nondescript chest pain. And they just asked a very simple question: what percentage of these patients ended up getting a CT of their chest, right? And what they found was in the 1997 to 1999 period, 2% of these patients with sort of nondescript chest pain ended up getting a chest CT. And then when they looked at the 2005 to 2007 period, what percentage do you think got a CT? Closer to 12%. So we're talking about like a 6-fold increase. And I said, well, that's kind of scary. I assume we're making a bunch of new diagnoses of horrible diseases. And are we making new diagnoses of horrible diseases? Absolutely not, right? The diagnosis rate didn't budge at all, but the imaging rate went up 6-fold, and they said, boy, this is really scary. Let's try to trend this out a little further. And they took that second block of time, that 2005, 2007, which is still, this is 6 years ago data. And they said, let's look at the first 6 months of that versus the last 6 months, just so we can get a sense of like the splay. And when they looked at it in the first 6-month period, the overall CT rate was 8%, and the last 6-month period, it was 16%, right, for relatively the same patient. So one can only assume what we're at now, like if that trend continued upward, I think we're at 118%.
Yeah.
My math is, I'm not 100% sure, but it's high. It's way too high.
CTing the family members who are also in the room.
This is very much like, you know, it's a lot, we've been sort of beating this PE CT thing to death, so I don't want to go into it in excruciating detail unless people have questions, but it is very much this, there's a don't want to miss, there's a legal ramification, there's a patient expectation, there's also like this field of dreams model, right? We sort of have a lot more CT scanners available, it's easy enough to just ship them over, in 2 seconds you get an answer to your question. So there's a lot of things that are contributing to this, and the message is the same. Again and again, we're doing a lot more testing, giving people a lot more radiation with no clinical benefit. It's clear that there's no clinical benefit.
Hospitals have a range of D-dimer normal, or do they have?
Yeah, this is a good question.
That's an outstanding question.
Very good question.
That we get asked a lot. The answer is yes. Every hospital has a range, because the way the lab reports values based on a range of values for normal human beings, for everybody who's alive, right? So if you have no disease going on with you at all, you have a range that is consistent with your laboratory standard, and it can vary from lab to lab, right? Now, what the literature does is it does something very different. All the literature with D-dimer uses the same cutoff, and what's that cut point? Got to know this. So, right, so 500, 0.5, 500, whatever you want to talk about. So there is that gray area, which is really important to understand. Like, for example, at USC, our upper limit of normal for D-dimer is 250. And a lot of people really misunderstand this, because I'll have residents saying, oh, we have a patient with a positive D-dimer. I'll say, what was the D-dimer? And they'll say it was 300. It's actually not positive, right? That's positive in the eyes of the reference range of normal people. So it's a laboratory positive, but if you want to trust the literature and use the algorithm, that is a negative. It's not 500. So the number doesn't change lab to lab, but the reference standard does.
When I was a director at an emergency department where the lab bought a new D-dimer machine about, I don't know, 8 years ago. And so the lab director came to me and said, where do you want to set this? And actually,
Fantastic.
from the manufacturer, you'll say, okay, if we set it at 250, you know, we're going to have more false positives, but we're going to pick up sensitivity, be better. So I actually got to pick.
What'd you pick?
And I picked the 500.
There you go.
And how many more people would we be seeing?
That's
Right,
that's
exactly.
exactly right.
You know, especially across the board, but that's it. The director of, you know, pathology came to me and said, this is what it is, what do you think you want to do? And we agreed on the one. So it's a statistical thing.
That's right. But the
Right.
only thing we have data on is the number 500. So that's the only number that I know what to do with. Other than that number, I'm just not sure because, like you said, at a lower number, I know there's going to be more false positives, et cetera, et cetera. So that's a number that in my head makes sense. And we've actually talked to people at other courses who said their labs are switching over to a positive-negative system.
Yeah.
Instead of giving you a number, which is just going to confuse you, they'll say D-dimer was positive or D-dimer was negative.
They're still gonna choose a cutoff point.
That's exactly right.
50, 300, 500.
So if you're in a positive-negative system,
You want it to
have
be
to know what
500.
your cutoff point
Yeah,
is.
you want that to be 500. Yeah. You had a hand over there.
Yeah, I was just gonna make a comment. I'm a PA, and I was just thinking when you were saying like this number is going up for these CAT scans, and I was thinking when I called my chest pain technician and I speak with the fellow, I was wondering why I get asked did I order a CT to look at a PE, and I'm like, well, I had a D-dimer on, but I wasn't really thinking that. But now maybe that's why we have a lot of CT.
Well, it is interesting. We had this last year, we had one of our medicine high honcho attendings come down and basically rip us a new one in the ER saying, you people are ordering all of these CT scans to rule out PE for clear CHF, clear pneumonias. What are you thinking? And I thought, wow, I don't think we do that, but let me look into it. And guess who was ordering those CT scans? It was the admitting services that wanted to make absolutely certain that that CHF was only CHF and didn't have a PE as well. So there's a little, and one of this is just not trusting the clinical diagnosis. And if it's CHF, it's CHF. You know, if it's a little CHF and they had sudden onset pleuritic chest pain and they were short of breath, and then that's totally different. But yeah.
That's actually the most important piece that's missing, I think, is why are they doing it? It'd be nice to know, are they looking for PE, or is it some other reason that they're ordering all these additional tests? I guess that's not really stuff.
It isn't, yeah. They sort of grouped everybody together as chest-related
It'd be nice to
complaints.
know that 80% of them are being done to rule out PE, or
My suspicion would be that it would be to rule out PE, because that's the diagnosis that most of us are terrified about, is not to miss.
Yeah, not in a non-trauma patient. Like
Yeah.
that's, you know, you can't think of many other reasons.
Or looking for little nodules that the radiologist says, you know, I'm not sure, hit your CAT scan, make sure it's nothing more before they go home, or a dissection, or whatever. I mean, there are a lot of other reasons that CTs are being ordered. I'm just curious what they would be, because of these numbers are pretty high.
Well,
Yeah.
they're now being, I know today there was a recommendation that came out for people that are high risk for lung cancer, smokers, et cetera, that they get annual low radiation chest CTs as a recommendation that came out this morning.
I want to skip 8. Thank you
Okay.
very much.
Hey,
Doesn't that?
that was easy. Number 9?
I want to do 9.
9's better.
9 is
That's actually a good paper.
this is a freaky
Yeah.
paper actually. Look at it. It's in the
great.
journal called the Clinical Applied Thrombosis and Hemostasis, which most of you might remember this issue. This is by Paul Stein, who's one of the big PE authors. He's the head author of the PIOPED study. And what they're talking about is isolated subsegmental PEs. And he says that the incidence of these things has been reported to be as low as 0.4% or as high as 0.18%. And with regard to these subsegmental PEs, he says that they can be found in asymptomatic people, that most patients with PE limited to the subsegmental area do not have concomitant DVTs. And that's important because if you don't have a concomitant DVT, there is no place for the next clot to come from, and that the clot burden, as you might anticipate, is small in these. And so He's basically looking at the mortality associated with subsegmental PEs in studies where they either treated them or didn't treat them. And he basically concluded that in studies where they were treated, the mortality was around 1%, and it was 0% in the untreated patients, respectively. No patient with a subsegmental PE in the 5 studies that they looked at had a fatal PE. Then they looked at what's the risk of anticoagulation. A meta-analysis of 33 trials of patients treated with anticoagulants for a VTE. The rate of major bleeding was 7% per year, and the rate of fatal bleeding was 1.3% per year. So basically, the numbers on bleeding and fatal bleeding far exceeded the morbidity associated with the subsegmental pulmonary embolism. So he says PEs do not require treatment, these subsegmentals, if the person has good pulmonary reserve, which you would expect that they would, unless there's COPD or something. No evidence of DVT on serial evaluation. So this is saying we really need to make sure that you don't have a clot in your legs, which could generate the next clot, which could be the big one. A transient and a reversible major risk factor for your PE. So you don't have cancer. You had some transient problem. You had a bump on your leg in a little car accident, and that's going away now. No history of central venous catheterization or atrial fibrillation, and if they can be counted on to return to get these serial exams of their legs, that it appears that you'll be much better off not treating these patients compared to the risk of bleeding that may occur. Now, to be fair, when he talks about bleeding, this is 7% bleeding per year, major bleeds, and 1.3% per year fatal bleeds, but that's taking this stuff for a year. Now, most people don't take it for a year. They're going to take it for some finite period of time, 3 months, 6 months, something like that. So this number is taking the worst case scenario in bleeding, which is a little unfair, but the case is still made that subsegmental PEs that are treated the treatment may be worse than the disease.
But that's the conundrum, right? That's the problem, yeah.
So you extrapolate that to people with AFib, 1.3 mortality per year, and people on AFib who are on Coumadin forever with a risk of stroke anywhere from 1.5 to 5%. Are we killing more people than we're helping treating Coumadin? Has there been an article?
Yeah, actually.
My understanding is that the ratio of harm to good, the good exceeds the harm, but there's clearly harm.
But there are also some segments of those people that aspirin is enough. So the warfarin isn't worth it on balance. And now that we have the newer anticoagulants, this thing is even worse as far as the things to be concerned about. These new at least warfarin you can reverse if you really have to. And the new stuff, it's just sayonara, Oh well.
Yeah, but a lot of people are thinking along the same lines you are. I mean, trying to come up with scoring systems and things like that for people with AFib to try to determine who is appropriate for anticoagulation and who is not. So
that's what Chad's did.
That's what Chad did.
And then Chad, they had to revise it because
Right.
it turned out they needed to lower the score a little bit for the warfarin group because they did find the sweet spot, or tried to find the sweet
They're
spot.
trying to find the sweet spot. But I think conceptually everybody agrees that, if there's some segment of the population with AFib that probably doesn't need to be anticoagulated or just get aspirin, but sort of getting that sweet spot has been the difficult part so far.
Mm-hmm.
And we see all the warfarin mistakes and errors, and not even when there are errors, these people come in with an INR of 11, and it's like, how do you do that kind of thing? You had 3 antibiotics for your bladder infection or something like that, and so we disproportionately are sensitized, I think, to the problems with warfarin. Good thing to know is that the FDA just approved a 4-element prothrombin complex concentrate on April 29th. So we are now moving from the dark ages. Canada has had this for 2, 3, 4, 5 years at least, and the rest of the world has had it forever. It's the same thing. It's called Kcentra, but in the rest of the world it's called Beriplex. It's been around forever. And why it took them so long to get this approved is beyond me, because the only approved treatment for elevated INRs in the setting of warfarin is fresh dose in plasma, with the dose being 1.5 mLs per kilogram. So if you have a 100-kilogram person, that's 1.5 liters of fresh frozen plasma that you're supposed to give. Well, this little bottle is this big, and within 30 minutes, all of the factors are back to normal. Now, the bleeding doesn't necessarily stop in 30 minutes, but the factors are back to normal. So I have no idea what caused us to drag that out so long, but it's here now, I guess.
Any questions or concerns about that topic? So we're going to switch a little bit to abstract number 10 looks at something that I find problematic, and that's the approach to calf DVT. So you have somebody come in, you get an ultrasound, they say DVT in the calf does not extend proximal to the popliteal. The issue with that is that 2 to 8% of those will propagate proximal to the popliteal, and then the risk of throwing that to it becoming a PE skyrockets. So the concern is, this is 6 randomized controlled trials that kind of looks at sort of what happens to these people and what should you do. And the reality is there's no clear answer here. I think what you end up having to do is sort of make a clinical decision on a case-by-case basis. If this is somebody who was in a long bus ride, it's a calf DVT, they're otherwise totally healthy, everything else is great, that reason that they got it is low, that person you can bring back and do an ultrasound if you want to in a week and see if it's propagated. If it hasn't, you're pretty much done. You also could make the argument, though, that that person is young and healthy, and a short course of an anticoagulant isn't going to particularly have a chance to hurt them. So you can make an argument to treat that as well. Again, then what you're treating is that anywhere between 2 and 8% that will propagate, but most of them don't. The other end of the spectrum is you have somebody who is frail and might be a fall risk, and where the Coumadin itself is not a great idea in that person, and perhaps the return ultrasound is better. And again, this just ends up being, there is not a clear answer to this one. If you look in the literature, there's not something that clearly says they all should be anticoagulated or they all should just come back for a repeat ultrasound. And I really think this is a case-by-case decision on whether you decide to anticoagulate or not.
What happens in the case where you're using this ultrasound as a way to decide, do you do the chest CT scan or not for somebody that came in with, their complaint is they've got this vertic chest pain and they feel short of breath?
Well, if they have a calf DVT and they're short of breath, they get, well, if they have a calf DVT and they're short of breath, technically, you probably don't need to do anything more except anticoagulate them. Well, because it's already gone. So that argument is it's already gone. The proximal portion is now in the lung, and you've diagnosed a clot in the leg. They have really good, sort of chest symptoms. You're pretty much, that's a person you would go ahead and treat and just treat. You don't need to image. We had a patient yesterday who had a documented DVT all the way up to the femoral. That, great, good on you. We got the whole anticoagulation thing started, got the patient admitted, and they did a chest CT. Why? Did they do? Why? Well, but that patient was fine. There wasn't tachycardia. But they handle it fine.
But the treatment is the same, isn't it?
And the treatment is the same.
Treating her leg is the same as treating her chest. And I remember a great paper that looked at lower extremity DVTs, and they did routinely on these people, they did lung scans in asymptomatic, and half of them had positive lung scans. So the idea is, oh, we got you just in time. I'm glad you're here. We want to prevent that thing from moving up there. Half of the cases had already gone up there, and they were, in essence, being treated as outpatient pulmonary emboli because they were asymptomatic, but their scans were positive.
My horrible hospitalist made us do it because he uses it as risk stratification versus the floor admission versus the ICU admission. So in this one case, I argued for not doing the CT scan. He did the CT scan and showed bilateral pulmonary emboli, the asymptomatic, extensive DVT, and he put her in the unit because of that. Instead of, I would say when I was doing malpractice.
Was there any benefit of putting somebody in the unit for that asymptomatic?
No, I
Like
wouldn't, I wouldn't assume
horrible
that.
hospitalist. Is that one word? Horrible hospitalist? That you're horrible hospitalist?
In most people in this country, you would use that as a decision for disposition. I mean, if it's negative, they go home. If it's a positive,
Asymptomatic though? Why would you go on to get, and somebody has a DVT?
most are not asymptomatic. They have some shortness of breath or tachycardia or something. But in this country, at least, still, I think, most PEs are treated as major.
They are, although it depends on what the symptoms are. If somebody's sitting there with a heart rate of 130 and a SAT of 90 and you're worried, that's fine.
Somebody's chest, and you find a PE, most likely they're not going
Although,
the
is anybody
Canadians
from
in the room.
Kaiser here?
Yeah, Kaiser in
So
Canada.
Kaiser has an outpatient program which they have
They published.
Yeah.
multiple times.
Mhm.
And when you think about it, if they're sitting there and they are hemodynamically just fine, they're going to be, and they're supposed to be ambulating around. They're just like every once in a while you got to get this pill or this shot kind of thing. It would like probably drive you nuts. And but as well. Anyway, when he drops dead, we want him to drop dead in the hospital. You know, that way we can get to them quicker, kind of thing. I mean, if I had it, I'd rather go home, I think, if I met criterion. The Kaiser, I think, has done a pretty good job. They've published multiple papers on this. Where are we here?
We're on number 11, and we're finally going to stop talking about clots and imaging just for a second. So it'll come back. This is accuracy of rapid influenza diagnostic tests, a meta-analysis. So this is a meta-analysis of almost 160 studies, pretty big thing, using a gold standard of a viral culture or PCR looking for flu. And essentially what they wanted to do here was they wanted to say all these rapid flu swabs, all these rapid flu tests that we're doing, how good are they in reality? How useful are them? How can we take the results of them? I like some of the names of some of them, you know, like one of them was called Binax Now. Yeah. And then there's Directogen. They all have very fancy, cool names that make you want to buy them over their competitors, I guess. And just so you know, the pool sensitivity when they looked at all these papers together was about 70%. So you're still going to miss like 30% of cases of flu with these rapid tests. The specificity was outstanding. It was almost 100%. So that means if it's positive, it's positive. You have the flu. The real question is, like, why do we actually really care about this if they have the flu or not? You know, I can think of a few circumstances clinically where this may be useful, you know, but generally, I think if someone's coming in with viral URI type symptoms and they're achy, I don't need a 3/4 sensitive test to tell me that they have the flu versus my own clinical exam. The only times I can think of personally where this might be helpful is sort of in extremes of age and things like that, where a person comes in on the elderly side and they're a little bit sick and you're like, hey, do I need to send labs and do kind of a septic workup? Or same thing in like a little kid, perhaps a positive influenza test there could, you know, prevent those kinds of workups from occurring. But we don't use rapid flu testing really in our emergency department. How many people do? About half.
Well, because the next question is you got $115 medicine that you're going to decide to give or not give. So if you routinely don't believe that $115 medicine does anything, then there's no point in determining whether it's the flu or not. But if you do believe that you might be able to buy some time or symptom relief with that medicine, then maybe you get into an algorithm where you do those tests. Particularly if it's on the shoulder of the flu season rather than dead center where everybody seems to have the flu and it seems like it's a waste of time.
Yeah, definitely if you're gonna use it, the shoulders are kind of the better time to use it than right in the middle where all of them are positive.
Yeah, right now, officially, they just 2 days ago declared LA County now influenza free, or down enough that we shouldn't be testing or taking all those poor people. Well, not poor people, but the people that refused to get the vaccine and had to basically spend the last, 4 months with a mask on every time they went to see a patient, they now can officially take the mask off.
But, you know, there's another aspect to this, which is who's at home. And, you know, a lot of times these people have babies at home, kids with asthma at home, and you need to ask those questions, because now it becomes an issue of, well, do you start prophylaxing people in the household, or do you treat this woman or this man because they have kids at home? That might enter into the decision making. Obviously, it's problematic if there's a high false negative rate, but at least if it's positive and they have a kid with asthma at home, then you know at least when we need to maybe do something.
But well, the false negative rate is not very high. First of all, it's like a pretty, and the false positive rate, it's quite outstanding. You know, if you're positive, you're positive. I mean, that's what this test says. What it says is you're going to miss a bunch of the cases, up to a third of the cases. So I mean, are you suggesting that like if you had a flu positive patient as a kid at home with asthma, you'd treat the kid with asthma with what?
With Tamiflu, you might prophylax or definitely would treat the parent.
I'm not sure that.
Yeah.
You're better off sending them home with a mask.
I think that's right.
As far as really truly wanting to prevent it, you know, the prophylaxis data, it's been approved for prophylaxis, but the data's not fantastic
In fact, it's
on
bad.
that at all. And you're really truly better off probably just giving them a mask and telling them to wear that around their asthmatic kid.
You can do that too. I'm just saying that's one of the reasons
Sure.
Sure,
Like I
sure.
said,
Oh,
there's always
absolutely.
little circumstances you can think of where even these tests that I would say generally are overutilized have some utility. Yeah, I named a couple. That could be one as well. But there's always going to be use for some test. That's why we have the test. Why would we have it if we never wanted to use it?
Go ahead.
Yeah.
Sure, and I mean, there's lots of other little. So he was saying, the school issue, sending the kid back to school. There's other reasons too. There's like surveillance reasons. So sometimes we want to know when the flu epidemic is hitting. So at certain times
what
of year,
type
you
of
might do, and
flu
what
it is.
strain it is,
Yeah.
and those kinds of things. So there definitely are circumstances. I don't mean to say we never use flu testing. I would just say in the peak, when everybody on Earth has got the flu, is probably a waste of time and money to do this test.
We do it for isolation. Anyone that's going to be admitted gets it if they have like a fever, cough, or sore throat, so that they can be isolated appropriately, which I think is fair.
Again, a disposition, if that's what the hospital says, like that seems very fair to me.
It is interesting though that they would use that as an isolation or not. If it's positive, great, but if it isn't, it doesn't mean that that person
That's
doesn't
right.
have flu.
We're at 5% PCR on all negative. If we have such a high suspicion of influenza
I see.
and it's rapid negative,
Oh, I see.
5% PCR to ensure that if they are admitted, they need to be isolated.
And how long does it take that PCR to come back? Yeah, it's like 3 days later, you're like, oh, they're supposed to be in isolation. So
And
She
this
just
is
water.
on everybody with an ILI? Is it everybody with an influenza-like illness that you do this?
Be admitted, yeah, during high flu season for us.
And we'll see what happens when the Chinese flu comes stateside. We'll see. We're all supposed to be keeping an eye out, right? Somebody who comes in with an ILI who it sounds like the flu to you. You have to ask about travel, see if they've been to China. The CDC's asking us to keep track.
12 is actually written by a friend of mine who basically goes through, you remember the Centaur score? Well, he's got the eBell score in terms of trying to tease out a recommendation to who to test, who not to test, what kind of symptoms do they have, and it's not something, frankly, that, if you wanted to use this, you'd have to put it on some kind of into your computer or ectopic brain or something to that effect. But he does talk about the shoulder season as probably being the most high yield spot to get these tests if you're going to do them. He looks at what the symptom profile is as well, giving various points to various symptoms. So I think that, it might be something that this guy is really smart. And so I give him a extra credit. And so if you wanted to come to some kind of solution or symptom, you could consider using that. 13 says do antivirals. This is a systematic review, meta-analysis of observational studies. Now, obviously, there are some people who have done similar analyses who don't come up with the same conclusion. In fact, I don't think the Cochrane folks kind of came up with the same answers. These guys are from McMaster, 74 observational studies on antiviral agents. The great majority of the studies were on Tamiflu versus no treatment. The quality of the data was judged to be low to be very low for most outcomes. So what we're going to do is we're going to take a lot of low and very low quality data and try to make good data out of it and put it together, this is adding, this is 2 second graders making a 4th grader kind of thing. The oseltamivir appeared to be associated with a 33-hour reduction in symptom duration. Some people would say that that's not true. Initiation of treatment within 48 hours of symptom onset appeared to be more effective than later treatment, and that's in the package insert. Evidence from observational studies of very poor quality data may suggest, there's a lot of mays and qualifications here, that early treatment with an antiviral might provide a net benefit for patients with influenza. This stuff is $115 for the 75 milligram capsules, of which you need 10. So, it's a matter of judgment to a certain extent. Not everybody agrees. What is your time worth? There's been a lot of secrecy about all of the trials on this stuff not being made available to the public, and major efforts to get all the data, and exposés that say this stuff really doesn't work and that it causes neurologic problems in Asia and other kinds of
That's abstract
things.
14 is the one that he's referring to, where this is an Australian paper where they basically did what was the equivalent of our Freedom of Information Act, and they said, we want to see all the study data on oseltamivir and flu, all of it, not just what you decided to publish, but all of it. And when they got all of it, a couple things happened. One, they realized that 90% of the data that came out of the studies was never released. Not that it was necessarily squelched, but it was never released, and then it took two people 14 months, 2 FTEs, 14 months to sort through all the data of just one drug being studied. One. Can you imagine if we tried to do this with everything that's studied out there, to really sort through the information? But the problem is that the concern was suppression of information. Things like they did know about the psychiatric issues that happened with oseltamivir, but that was not particularly touted. That was in the database. They had on all of their data. They knew, and it wasn't all promulgated, which is a problem. I mean, that's an issue, and it's very hard to get out all this information. Again, it takes a lot of people a lot of time to get in there and see what's what. But I'll tell you, the oseltamivir marketing was brilliant. We are a disaster resource center at our hospital. So if there is the big flu that happens and we all go down in the mine, we're all the canaries in the mine with us, we have this stockpile. There's tons of it there, but there's not a lot of data that really says it does much at all. I mean, we treat patients. There's a prophylaxis that was referred to up here. It's been approved for prophylaxis. 6 weeks you're supposed to be treating with prophylaxis. Crazy, 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 crazy. So this is just a kind of a sobering paper that says there may be a lot behind our research that we never, ever get any information about. That's data that's out there we just never access.
Okay, on that highly uplifting note, we'll go to abstract number 15, which is processes of care and outcomes for community-acquired pneumonia. Basically, we know that we have certain requirements now of patients who come in with pneumonia, and we have 4 of them very specifically: to document, check an oxygen saturation level on these patients, to get them timely antibiotics, defined as within 4 hours, to choose the right antibiotic, that seems to be a good one, and then the last one is to get 2 sets of blood cultures before we give those antibiotics, right? So those are the 4 things we're mandated to do, and they sort of ask the question here, looking at over 2,000 patients, does doing these 4 somewhat relatively arbitrary things actually have some patient-oriented improvement? Like, do they do better? Do they have less mortality? Do they get out of the hospital quicker? Do they get out of the ICU quicker? Like, does following all 4 of these things really have any impact on any of these clinical indicators? Like, you know, if we actually care about the patient, and we can go through all the numbers, but what do you guys think? Yeah, of course not, right? I mean, doing the patients who got all 4 out of 4 things undocumented didn't do any better than the ones that got 2 or 3 out of 4 things done and documented. Now, you know, that being said, I don't want to, it's kind of like thinking, okay, no mandate is actually going to magically fix everything and make patients 100%. Like all of a sudden, oh, your mortality decreased by 50%. Yeah, we know that no mandate that has like numbers and things like that is going to do that. But I do think that the general principles that they express here are good. I think that pneumonia patients, if they really have pneumonia, we should be thinking about getting them the correct antibiotic early. That seems very obvious to me as a good thing to do. You know, the questionable one here, of course, is the blood culture issue. I know we've had tons of issues with false positives and things like that at our hospitals that then warrant a, you know, trip back to the emergency department for what turns out to be a contaminant. But, you know, I think I'm going to, since the last paper was such a downer, I kind of want to end this one on a positive note. I think the spirit behind this mandate is good. It's to get us to get these pneumonia patients antibiotics correctly early, but the actual sort of tenets of the mandate themselves are sort of ridiculous and aren't going to do anything if you follow them versus if you don't.
Yeah, that was pretty uplifting.
Hey, it was better than the previous one where it was like, can't believe anything you read because 90% of it you don't get to read, so.
16 is about people who have psychiatric disorders get less pain medicines. Now, I don't know whether that's good or bad, but it was pretty marked here. The rate of opioid administration during the ED visit of patients who were discharged was about half as likely for psychiatric diagnoses than they were for those without. It was 33% versus 18%. And between 1993 and 2005, prescription of an opioid increased from 25% to 42% in patients without a psychiatric diagnosis, where it went up barely from 17% to 19% if you had a psychiatric diagnosis. I think the point of this paper is that people who have psychiatric diagnoses, at least the doctors in this study, tended to take them less seriously, give them less opioids than not. And this is a national survey, so it's extrapolatable to the whole according to how the National Hospital Ambulatory Medical Care Survey is conducted. So I guess this is a suggestion that there may be some prejudicial lack of use when you say that you have some kind of psychiatric diagnosis. You know, we've done this at other courses, and there have been people who said, well, you know, I don't know that it's inappropriate that we use less, maybe, but my own kind of view of this is that this is consistent with the kind of the oligoanalgesia kind of thing, and that instead of just race, now we can throw in race and age and psychiatric diagnosis into this pot of things that basically allow us to feel comfortable using less analgesics, and especially less opioids. But I got to believe that there's another side to this out there. So anybody want to take another point of view?
Go ahead.
I definitely have another point of view. I work in inner-city-ish population in Schenectady, New York, and we have addicted the population to opiates. And I spend, I don't know, hours of every shift dealing with people who are coming in clearly looking for these drugs. 4 times over the past year, people have come in with cellulitis. When I walked in the room, it looks like cellulitis. It's exactly what it is, but it's always cold when I touch it, and sure enough, when I wipe it with alcohol, the cellulitis is cured. And you know, it's pervasive. It's everywhere in this population, and it's our fault. And I feel like as a community, as a profession, we have just ruined these people. And I feel very strongly that we're using way too many opiates for pain that is just not identifiable. We have no diagnosis really, but we throw opiates at it because we're trying to make everybody's go away faster.
Well, you know, you saw the response to that kind of your view in New York City, where municipal hospitals are allowed apparently only to issue 3 days worth of opiates. They're not allowed to refill any prescriptions that were eaten by the dog. And what else was in there?
They're stolen. They're stolen. They're not eaten by the dog.
And they're not talking, and you know, no OxyContins or anything like that. So that was the mayor's response to the problem that they have there.
And there's a full half-hour section on opiate use and stuff. I can't remember if it's tomorrow or Friday. This is while we'll dig a little bit more deeply into these details of what to do with sort of this drug-seeking patient.
That dictum is the whole state of Ohio. The governor of Ohio, about a year and a half, 2 years ago now, had a whole task force on this, and the Ohio Attorney General, the Ohio State Medical Association, the Ohio Hospital Association, every major, you know, medical group came together and put, and it's very similar dictums to that, like out of the emergency department, what you're to be prescribing, what not, what you're even to give to the emergency department. But that all comes on the hand of what is one of the leading cause of deaths now in age group 20 to 35 or 40, and what's, you know, escalated right up to the
But you know what? We're not the problem. We're not the problem. We prescribe 10 to 15 of something. The renewal is the 80 to 120 pills. We're not the problem. And this is a very double-edged sword here.
In Ohio, it was precipitated by a small county that had, I think, like 40,000 people were in this county, right? There's like 10, 15 million people live in the state of Ohio, but their percentage of opiate prescription on a statewide basis was some tangible, like 12 or 15% or 20, some ridiculous
Sure.
percent building, and that's where it all.
Right. My worry about this is sort of two. Actually, why don't you go ahead and then I'll pitch in.
Because if the patient is coming in and they're having a psych crisis, we handle the psych crisis, and then you didn't address the pain, you didn't go back to assess the pain. The patient was
Well, I don't think that they had psych crises. I think that they had a
A psych
painful
diagnosis,
condition, and
yeah.
somebody said, "Yeah, I take antidepressants, and yeah, that's one of the things. Okay, that, you know, the light goes on.
This is just it's a horrible situation all the way around. One of the unintended consequences of these limitation laws and rules that are being put out there is, guess what's now the fastest growing drug abused in this country now that they can't get access to the prescriptions? Heroin. How many of you guys are seeing heroin? And it's happening in our college kids, and it's happening in the kids that live in the fancy schmancy houses, because they're the ones that take mom and dad's Percocet, and now they can't get the Percocet, they're using heroin. And it is skyrocketing nationwide. So we have a whole spectrum of problems now. And they're using it mainly snorting. They're not shooting, although shooting is increasing now as well. So we're going to go back to IV drug use as a problem, back like it was in the 1960s. But it's sort of like a manifold issue here. I do think as a society we've got to address this. I'm not sure that we are the problem, though. And the idea that the ER shouldn't be prescribing X number of meds is, we're not the problem. We see the cancer patients that have the pain. We see the acute fractures. We see the burn patients. We see the people with the acute stuff. And I'm really worried that the pendulum is going to swing so far that we're hesitant to treat, honest to God, my goodness, that's got to hurt, kind of pain appropriately. So there's got to be sort of a gradation of this, and truly we are not the problem. The reality is we prescribe two kinds of medicines in the ER, antibiotics and pain meds. But we don't prescribe a ton of either for any duration, and the ongoing renewals are the major issue here. So it is manifold, and it is extraordinarily complicated. But I'm already seeing, just in this year in this course, people saying, I don't give narcs anymore, or I give a Motrin first for their fractures. And it's like, really? 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 Yeah.
I agree with you that we're not the primary problem. However, we have access to multiple Boston hospital records in emergency
Yep.
rooms, and you see these people who go to each emergency room and get 15 years.
Now that is helpful. So access to these databases is great, because you can then say, we need to have a talk. Right. You did, each ER doc is doing the right thing, or ER person is doing the right thing, but you can't see 3 in a day. That is, we have an issue here that is separate from your pain that you have. You have to legitimize them, but it's different. We now have a different issue. And those databases are great. They're really helpful.
Yeah, we have one in California too.
Mm-hmm.
Well, everybody knows that psychiatric patients are at the highest risk for opioid abuse. And so wouldn't you expect to find that if providers are being responsible, that they are more cautious with patients?
I think there's a lot of reasons with psych patients. I think there's a lot of reasons that we may prescribe less. Anything from not being comfortable, being able to, because pain is subjective. I mean, we have pain scales, and there's no measurement. You can't say, I'm going to get a pain level and send it to the lab. So you have to sort of trust the patient. And if there's a communication issue, which is why sometimes ethnic groups are an issue. You can't communicate, or they manifest pain differently. So I think it's really complicated on the psych patient. And I'm not sure this is a bad thing, the way this study says. This may very well be that's the best they could do, given the interaction with the patient. I don't know. I think psych patients are quite difficult, and yes, you're right, they're at risk for addiction, depending on their psych condition, more than others might be.
Aside from the dependence issue, I know one thing I'm kind of guilty of is we see so many of our overdose patients have bipolar or schizophrenia,
Mm-hmm.
school. You worry, okay, maybe you don't give them more than 15, like 20, whatever, but you don't want to be the one giving the Vicodin that they overdosed on, and you came back in later, so you're like, oh, at least for the prescription, I know I sometimes hesitate a little bit, and maybe it's not justified to do that, but I know it's one thing that sometimes goes through my mind.
Sure.
Well, this paper does talk about the rate of opioid administration in the ED. It's not necessarily about prescriptions. So yeah, and there is a half hour on this. No great solutions, but it just actually explains the dilemma all the more.
Well, it's a good discussion. It'll probably take my half hour down to 15 minutes.
There you
now,
go.
So thank you guys.
No
Appreciate
problem,
that.
No problem.
Are you going to talk about PCA then?
17 is about
Not.
PCA.
So you're not going to talk about PCA?
We are not in that
Oh.
section.
This paper basically said that it turned out to be a reasonable thing to do in this Albert Einstein paper, where they looked at 206 adults, acute abdominal pain, judged to be candidates for IV opioids, and they compared a couple regimens there, and basically adverse effects were infrequent and similar in the 3 treatment groups. Patients randomized to PCA were much more likely than those not so managed to report satisfaction with pain management. It's kind of like, why is the ER being excluded from this modality when it's used in the hospital in other settings and post-operatively, and it's been viewed as a successful way of addressing pain, and yet we systematically want no parts of this. And then one of the problems is that in the ERs where we're busy, you know, the patient is asking for pain shot again for his kidney stone or whatever back in bed 3. By the time, so there's this up and down kind of thing where they get, you know, nothing lot kind of thing. And have any of you incorporated PCAs in your ER? Have you, any of you tried and it didn't work, or somebody, you know, because I hear, well, you got to teach the nurses how to do it, and it's kind of cumbersome, and that. And I, you know, it seemed to work on the floors. And there are people who are going to have chronic, ongoing pain while they're in the department. You know you're going to need to give them multiple boluses of this stuff for that kidney stone or that bad burn or whatever, or that nasty fracture or whatever they have. But so we're nobody here. Even the New Zealand people, no?
It's last course we did, there were a couple people
No.
who
Yeah.
had done it in their ERs,
No.
and
They were really happy
very
with it.
happy with it. And it's one of those things where there's this setup time to get it all set up, but honestly, it unburdens the nurses once it's going.
Get the pharmacist to do it.
They don't have to go back to the patient over and over again. The patient, how many of you had a PCA, patient-controlled analgesia of your own? Because I did. I had orthopedic surgery, and it was magical. And there's a couple things that come out in the literature about this. One is you use less drug overall. The second thing is giving the patient control. So they've done sham studies where no drug is given when you push the button, but just the fact that you have control of your own pain. And it's probably an endogenous endorphin issue, it's placebo effect, but probably your own endorphins that have something to do with this. But it sort of ramps everything down and puts the patient sort of in the driver's seat. We actually tried this. Our nurse, we all know that the people who truly run the hospital, separate from bed control, are the nurses. And our head of nursing basically said, no flipping way. I'm not asking my nurses to do this. So that was a non-starter for us. But I think it's a great idea. If you want to go to a pain-free ER, this is one of the things you can do relatively easily that really works great. Abstract number 18 basically says, anytime you write a prescription for an antibiotic, which we do all the time, right? It's one of the biggest things we do. Look at the meds list. If the patient's on warfarin, know that virtually any antibiotic you're going to prescribe can muck up their INR, can bump their INR. And it can bump it to a significant level to the point where it's not in this paper, but the increased risk of things like hospitalization, serious bleeding, et cetera, from their INR being bumped. What does that mean you do about that? Well, I think it depends. I would not change somebody's, first I would check their INR now just to see where it is today, so I have some idea. But separate from that, I wouldn't change somebody's warfarin dose just because I'm giving them an antibiotic. But if it's somebody who's going to be on an antibiotic for more than a couple of days, that person should probably get their INR rechecked within a relatively short amount of time. This is competing with your gut flora. It's changing how you absorb vitamin K. It does a lot of things to give an antibiotic, and everything interacts with warfarin, but antibiotics obviously do. So it's really worth it. And this is where an EHR, if it works right, can be great. You click on an antibiotic in your EHR, and it pops up a little screen that says, is the patient on warfarin? Makes you think about it, because you don't usually when you write prescriptions. And what you do about it is just make sure that their INR, when they start, isn't already high, and that if it's a prolonged course of antibiotics, more than just a couple of days, they probably should get rechecked.
Yeah, and I don't think Abstract 19 really adds much more than that. It's essentially giving the same message that, you know, we give a lot of antibiotics in the emergency department, and almost every antibiotic you can name has some kind of interaction with warfarin. So we need to be cognizant of it. And think about checking INRs and thinking about bringing those patients back early for a repeat INR check if we're putting on something that we know will sort of mess with their anticoagulation.
It's remarkable how it can happen. When my father was dying, my mother was on Coumadin, and she, right around the time he was dying, developed gum bleeding. I was like, what is going on? And her INR was 11, but her doc had treated her by an over-the-phone over the phone call about UTI kind of symptoms, which turned out not to be what she had in the first place. But she was put on an antibiotic prescribed over the phone and ended up with an INR of 11, which goes to abstract number 20 is what you do if they're asymptomatic with an INR of 11.
Well, you know,
Say it again.
How soon should they have it checked again? If you saw somebody on
That isn't clear, but probably a couple of days is good. 2 or 3 is when it's going to, because what it does, it has to change the gut flora first. So a single dose doesn't usually do it. And 1 day course probably doesn't usually do it. But they get into more than a couple of days again. I don't know that anyone knows exactly what day. So I think the safe window is a day or 2.
I'd say 2 to 3
yeah.
maybe. That sounds right.
yeah, and it's any antibiotic. There have been these papers that say, well, let's classify what are the high-risk ones.
Yeah.
For every paper you find this list is the highest ones. You'll find another paper that says this is the high. It's anything that kind of screws up your bacterial bowel flora. But you know, one of the most common ones by far is Bactrim, because we give that, not only do we give that for urine infections, but we now give it for all these skin infections, which nobody ever heard of before giving Bactrim for a skin infection. So it's become really, really popular. And on the lists, this is generally one of the drugs that has been most effective in raising INRs. And it's consistent. It's not idiosyncratic. It's not a weird reaction. It is just, you can count on it happening. So then the 20 says, can you go home if you have a super therapeutic INR? Actually, the American College of American College of Physicians?
It's
that
the
has-
chest
physicians has a guideline, which I think probably is worth following, so that you can have somebody to hold your hand with in terms of the dispositions that you're making in patients who have INRs of this or that, because they go through certain ranges and certain recommendations, more so than just one single paper here. So I would recommend that if you are going to treat these patients, which most of them can be treated as outpatients for sure, absolutely, unless you're going to bring them in the hospital and put some bubble wrap around them for a few days so nothing can cause them to bleed. This paper concluded there was no evidence that outcome is dependent on hospital admission in patients who are not at increased risk of
But
bleeding.
you also shouldn't go charging ahead with something like vitamin K, which mucks things up
Right,
for
so
a while.
I think honestly the answer is to get the guidelines and follow them, because sometimes you're not going to feel all that comfortable
Yeah, you can
dealing with
Google
somebody with a 6 or 7.
ACCP anticoagulation guideline, because it's kind of hidden in another document. It's hidden in a more overarching document. But if you Google ACCP anticoagulation guideline, and then you can hit images, it'll usually pop up that table. And in a lot of the downloadable smart apps things for your phone, you can actually, it's integrated into that. It's basically what do you do with elevated INRs. And there's one, just to make a little plug, there's a free downloadable app for emergency medicine called Wickham, WIKEM, free download. And in there, under the heme section, these guidelines are in there. So you just basically click on it, it pops it up for you. It's a free download.
And the guidelines they're very straightforward too. It's
Yeah.
not like they leave a lot of room for ambiguity, which is really nice. They sort of have these set cut points of INR less than 5, between 5 and 9, and then greater than 9, and what to do. And I mean,
Based on symptoms and bleeding.
yeah, based on, they categorize it basically just based off bleeding. And the easy take home, if a patient is not bleeding, regardless of their INR, they don't need any sort of parenteral vitamin K. That's for 100% sure. That's the easy take home from the guidelines. And if you're going to give PO vitamin K, like Diane said, it's very case dependent, because there are some very high risk conditions for why a patient may be anticoagulated in the first place, you know, like a artificial valve or something like that, versus a very low risk condition like a DVT, you know, with otherwise healthy patients. So you always have to weigh the pros and cons before giving vitamin K, but those chest guidelines are pretty solid. They're pretty straightforward.
Let's stop here.